Is that correct?
Yes.
Okay. Well, welcome everybody. We will get started in 2 or 3 minutes. Well, good morning, everybody. This is Patrick Jones at Eastern Washington University coming to you from cloudy Spokane. I hope that the weather's been good to all of you who are participating today. We've had several inches of snow up here, but that's largely melted away right now. So it looks like Thanksgiving will not be a snowy Thanksgiving in Spokane County. Today is our last meeting of our Leadership Council for the year 2020. And it's really a culmination, the content is a culmination of so many of the topics that we have covered to date. And in particular, looking at how we might operationalize the many reforms that are part of the transformation project, because without the ability to extend incentives and payments to providers by the payers, this will remain an experiment. And so for sustainability reasons, if nothing else, the team at the ACH thought it would be very important to provide a bit of a summary of where we're at with value-based payments as of this point in time. And as you can see from the agenda, we have invited two folks from the HCA to give us the big picture and to also let us know what the HCA's policies and intent going forward might be, if we don't know that already. And then we'd looking for a response by, first of all, the providers. And as you can see there, we have 4 providers lined up, from 2 from within our region and 2 from without. And then we have a set of responses by the managed care organizations. As you can read there, 4 of the 5 in our state will be giving some remarks. We're going to try to keep this as interactive as possible. So we've asked the panels to keep their comments, whether with PowerPoint slides or not, to keep their comments to 6 to 7 minutes. So we have time for questions from you, the audience, and we will be looking at the chat box for those questions. And then at the end of the meeting, if there is any time, we'll just throw it open for some just wide-ranging comments. Normally, we would go around the room and just tell each other what we're doing this coming Thursday, a week from today, with our family. But in the interest of time, we are not going to do that. And I'm sure that the plans are as varied as the number of people in the room. So that would probably just take up too much of our hour. And we know that we really would like to come away from this session this morning with a greater sense of where we are as a state and where we are as the Greater Columbia ACH in facing, adopting value-based payments. So we have, first of all, a PowerPoint presentation from the Healthcare Authority. I don't know whether J.D. Fisher or Mia Nafziger, our 2 representatives from the HCA, will be doing this in tandem, but I'll defer to, in alphabetical order, I'll defer to J.D. since you're listed there first, and JD, the floor is yours until approximately, you've got about approximately a half hour. So,
all right.
Take it away.
Well, thank you very much. And just a quick question, are we able to present our screens, or are you presenting the slides?
Hi, JD. Yep. Should I change it to you or Mia?
Please change it to Mia, unless I think.
Oh.
We ran through this yesterday and it worked fine with her running it, so.
You got it.
Let's
Mia, you should be receiving a notification right now.
And
Perfect.
just
All
by
right.
way of introductions, I'll have us both introduce ourselves real quick, and then we'll jump in. My name is JD Fisher. I'm the Value-Based Purchasing Manager at the Healthcare Authority within our Policy Division. At a high level, my role includes coordinating our purchasing strategies across the agency, so across our Medicaid and employee benefits programs. And Mia, do you want to introduce yourself, and then I will get started on the deck?
That sounds great. Thanks, JD. My name's Mia Nafstiger. I work for JD in the policy division on our value-based purchasing team, and I work on a variety of projects relating to both value-based purchasing and our health equity work. And we're really excited to be here. Thank you for having us.
Yes, thanks for having us. And a few things about the deck. You should have it in your materials, and it is quite long. There are a lot of extra slides in an appendix at the end. Given the time frame, we wanted to try to hit the high points, but give you some material to look through. We will be publishing statewide results in a slide deck to the website in the coming weeks, so there will be a broader analysis available. And of course, we'd be happy to come back and talk through specific questions or just have further dialogue at a later date. So let's jump in. So we're gonna walk through some background about who HCA is and what our value-based purchasing roadmap is, and then we'll get into some of the survey results. So Mia, can you move to slide 3? So we are a purchaser, convener, and innovator. You may have seen this slide or its contents before, but we purchased for healthcare for about 2.5 million individuals through Medicaid and public and school employee benefits programs. We implement innovative strategies and have received funding from the federal government in various settings through the 1115 Medicaid transformation waiver, which is still ongoing, and we are looking to extend that through 2022, and also through the State Innovation Models Test Grant, which was a $65 million grant from the federal government several years ago. We've done a lot of work in the employee side, including implementing centers of excellence for total joint replacement and spine fusion, and continue to iterate and look for opportunities to expand our purchasing strategies. Next slide, please. We publish an annual roadmap that details these strategies, successes to date, and future plans. We have set goals for the agency's state financed purchasing, and we hope to meet or exceed 90% of state financed healthcare payments tied to value by the end of 2021. We have interim goals along the way, and we just were able to calculate our performance for 2019. And unfortunately, 2019 is the first year that we failed to meet or exceed the interim target. There are a number of reasons for this. The managed care side of the house is doing much better. You'll see later on that the MCOs are in aggregate 73%. And on the employee side, we're struggling to move the needle too far. There's a number of reasons for that. One is our most popular benefit option is our essentially free-range PPO that is fully fee-for-service. We have done some work with our third-party administrator to add some value components to that benefit option. So we're hoping that in 2020 we'll see improved results as that program will be amended. And we've also had an ACO model that employees can opt into, and then of course Kaiser Permanente has extensive value-based purchasing activities. But all that to say, there are some challenges ahead. And next slide, please. Just as a refresher, when we talk about value-based purchasing, we are using the Healthcare Payment Learning and Action Network's APM framework. What you're seeing here is a refreshed framework that they published several years ago. In all our contracts and templates and reporting, we have used the original framework, but we will spend time over the next year adopting this refreshed framework and implementing that into contracts and reporting tools. There aren't many differences. Really the only difference is that the refreshed framework removed category 2D, which was penalties for performance. So think of the inverse of pay for performance. We didn't really see hardly any adoption of APMs in this category since we've started this work. So I think it makes sense to remove it. And then the refreshed framework also includes a new category in category 4, that's 4C, which is integrated finance and delivery systems. So these are systems where the payer is also the healthcare provider, or they are closely connected through kind of contracts and shared risk. So think of Kaiser Permanente, their standard model would fit this category. So to date, our guidance for payers who report, say in the survey, and they have an integrated delivery finance and delivery system, we've had them just report in category 4B. So this will just add some specificity and detail that we think will be helpful, and it'll help us keep up with kind of latest definitional work being done at the federal government. Next slide, please. This October, we published another iteration of our annual roadmap, but this time we took a view of the years beyond 2021. So our goals for VBP really end at 2021, and we know that the work is not going to end. So we need to start thinking about what is our vision for the years beyond 2021. What do we want to happen in those next several years? We will continue our shift from paying for volume to paying for health and value. And we will ensure that payment continues to drive key things like lower cost, high quality service, but also greater health equity and improved access. We've always, valued those two things, but we haven't specifically called them out. And we think it's very important that we do that and integrate those into our foundational strategies. So next slide. Our vision for VBP in 2025, that our purchasing arrangements will be aligned across all public purchasing programs and advance multi-payer primary care models where appropriate. We do believe that a strong focus on primary care and behavioral health is critical to not only success in VBP, but improving the health and well-being of Washington residents. And we will leverage our purchasing power to continually drive the healthcare system towards improved outcomes, experience for both patients and providers, and improving equity, all while containing costs. Quick plug here, this last year, the legislature passed a bill to establish the statewide healthcare cost transparency board. So we hope that that board will be influential in the coming years in shining a more transparent light on healthcare costs across the state. And HCA will be tasked with facilitating that board and be closely tied to that work. So more to come there, but just a quick plug. We expect that VBP arrangements will be rooted in data-driven policymaking, which will really allow us or enforce us to collect and utilize actionable data, both when we talk about accountability for our partners, but also exercising oversight and monitoring our priorities, monitoring progress, and ensuring that we can adapt and improve projects and programs over time. We've spent considerable effort over the last year reassessing our internal data capacity and data strategy, and there's a lot of internal work going on to help get us to this place. We also refreshed our foundational principles. I'm not going to walk through all of these, but want to highlight a few additions or changes. So you see there on number 2, we've added affordability and accessible care into those things that we want to reward through our purchasing. Number 3, this is some rewording of a similar principle before. We want to support the delivery of whole person care centered on robust primary care and other prospective payment APMs. This is really important, and some feedback that has come out, especially throughout the pandemic, that having prospective payments where providers are getting a predictable, steady, constant funding stream allows them to kind of navigate disruption a little bit better. And so we think there's a lot of value in prospective APMs, not just for the pandemic, but just in general. When we talk about behavior change and coordination of care, payment upfront can drive a lot of these improvements. We want to approach all purchasing with a health equity lens to continually improve health equity for all Washington residents, regardless of where they live, and actively address their social determinants of health. We have a lot of work internally to develop a strategy for health equity, and there will be more to come publicly on that. We will be doing some community engagement in the coming months, but right now we're doing a lot of internal work to get on the same page. And then number 7, to engage in data-driven policymaking to advance standardization and care transformation. So next slide. We also identified several key priorities for the agency over the next several years. These are in no particular order, but they are health equity, social determinants of health, primary care, alignment across the agency and across programs, accountability and support for our contracted partners, access and affordability. The long-term roadmap lays out the what, why, and how for each of these priority areas. And due to time, I'm not going to go into much there, but I encourage you to take a look at what we laid out there, and I think it's a useful section of the document. Some new APMs and programs that are either under development, under consideration, or under development or under consideration at the agency to kind of fit within these priority areas. We are developing a multi-payer primary care APM. We actually just had a memorandum of understanding signed this fall for that. We're developing an aligned child health primary care services APM that would fit very closely with that multi-payer model. We're looking at opportunities for rural health transformation. We've looked at the CHART model and are considering that, but also considering some other statewide opportunities. We are participating in the Advancing Health Equity Collaborative in partnership with the Community Health Plan of Washington. And we are implementing the Cascade Care public option in partnership with Health Benefit Exchange. So I encourage you to take a look at the long-term roadmap and would be happy to discuss more at a later date when we have some more time or answer questions via email. So we'll talk quickly about the Paying for Value survey. So I'm not going to spend a lot of time on background because by this point, most of you are probably very familiar, but we do issue an annual survey to health plans and providers to track progress towards our VVP goals and to gather information that can help us understand opportunities for current and future strategy design. So first, the health plan survey. This year, 5 MCOs responded to their contractually obligated VVP validation process. So as a reminder, there are separate surveys and templates that go out to the MCOs and Medicare and commercial health plans. So this year, all 5 MCOs successfully completed the VVP validation process, and we had 8 health plans respond to the Medicare and commercial health plan survey. So note that all 8 of those plans are contracted with HCA in one form or another. We'll go over some quantitative results first. So in Medicaid, Medicare Advantage, there were 7 health plans that responded and had some business in Medicare Advantage. Their total payments equaled about $3.1 billion, and overall, they were at 76% VBP. You'll see the largest shares in category 4. For the commercial market, there were 6 plans equaling a total payment of about $11.8 billion, and altogether, commercial plans were at about 64% VBP. And then the Medicaid managed care plans, all 5 with a spend of about $4.2 billion, with VBP accounting for about 73% of that. So when you look across these, in aggregate, our statewide total is about 69%. So you'll see that's an improvement from last year's survey results of 59%. So there's steady improvement. There are some interesting differences in where APMs are being implemented, and as far as the categorization goes. You'll see Medicare Advantage is putting a lot more APMs into category 4, which are more population-based payments or global budget capitation payments. Commercial market is very much more varied in terms of a distribution across categories 2, 3, and 4. And then in managed care, the focus is largely in category 3, which are APMs that are built on a fee-for-service chassis, but have considerations for total cost of care and opportunities for shared savings or two-sided risk arrangements. So there are some good reasons for that, different provider scenarios and capabilities and everything, but still some interesting differences. So next is the MCO VBP adoption by Accountable Community of Health. So the biggest thing here is that all ACHs save for Healthier Here saw an increase in VBP adoption, and Healthier Here saw a decrease of only 1%. Take a look at Greater Columbia. The region was at 67% for 2019, which is below the target of 75%, but still an increase of 13%. So we knew these targets were going to be more difficult, but it is encouraging to see progress still being made. So interestingly, there were 1, 2, 3, 4, 5 regions that exceeded the target, and the remaining fell below. So we have some, I think we're going to have some conversations with our managed care plans and with ACHs to kind of understand what a little more detail about the challenges. We've heard a lot from the survey results, but we definitely want to make sure we're not missing anything. And some of the qualitative results from the health plan survey, quick note, these are only from the Medicare and commercial payer survey, as the MCO templates through their VBP validation process don't include any of these questions. But as far as enablers and barriers to implementing VBP, there's some commonalities here where when you have something, it's very helpful, and when you lack it, it's a huge barrier. So interoperable data systems, when they're present, they're facilitating VBP adoption, and when they are lacking, it's a barrier. When there are aligned incentives and contract requirements across APMs, that's a facilitator to implementing VBP. Where there are disparate incentives or contract requirements, that's a barrier. Where quality measures are aligned across provider groups and contracts, that's a facilitator. When they are misaligned, that's a barrier. And then the last unique enabler was trusted partnerships and collaboration. So health plans are saying that's a very important aspect to implementing VBP. And then a barrier is payment model uncertainty. So this can range from uncertain as to how the payment model, how the health plan and providers will perform in the payment model, uncertainty as to whether the measures are correct or the design is accurate and impactful. And then the last slide on the second to last slide on the qualitative results. And I only want to highlight 2 things here. So we asked which provider types plans are engaging in APMs, and 7 health plans reported that they are contracting with many primary care providers for APMs, and 5 responded indicating that they were contracting with a select group of behavioral health providers. So to me, what this says is that the focus for APM implementation is really honed in on primary care and behavioral health. And we think that is very good. That is important. Those are critical areas for driving health improvement and reducing costs. And then we did ask about the impact of the pandemic and COVID-19. It has affected organizations' ability or capacity in a few ways. It has reduced the willingness or ability among providers to engage in new VBP contracts. 5 plans said yes to that. 2 plans reported challenges to sustaining provider networks, and 7 reported negative impacts on quality measures. When asked how payers, purchasers, and providers should adjust strategies in light of the pandemic, 3 suggested reducing risk-based payments until the pandemic is over. 5 suggested continuing to expand VBP models. 4 suggested implementing prospective APMs. This gets back to the predictable, steady income and revenue stream. And then 4 recommended pausing the expansion of VBP instead of focusing on, and instead focusing on sustaining access. So HCA has already done a number of things in the pandemic, and we're continually looking for opportunities and ways to support our partners, but also maintain access and ensure that our clients are and members are getting the care that they need. So we've expanded the use of telehealth. We've relaxed some of the VBP requirements in the MCO contracts for 2021. And we've looked at, we've continued moving the needle on the development of the prospective multi-payer primary care APM. So a few things, but we're always, we're looking at quality measures and other opportunities. And I'm going to hand it over to Mia, who's going to talk about the provider survey.
Thanks, JD. So this first slide shows what types of provider organizations responded to the provider survey. And on the left, you have our overall results, which we had about 170 organizations respond to this question. And on the right are specific to Greater Columbia. But you can see there are pretty similar patterns between the two. And there's many providers who responded had some type of behavioral health provider within their organization, followed by quite a few outpatient and clinics or facilities. This slide shows how respondents, which service areas they indicated that they worked in by ACH. And if you look at Greater Columbia, 32 of the 165 respondents to this question said they worked in that region, which is an increase of 13 from last year. And you see a similar pattern on this slide, which is respondents who stated that they worked directly with a given ACH. And again, you had 29 from Greater Columbia, which is an increase of 17. So quite a few more providers from the Greater Columbia area responded compared to last year. This is a pretty simple chart, how providers felt they were doing in terms of VBP readiness and capability. A decent proportion felt somewhat ready or even not very ready, although 19 said they felt mostly and 13 said very ready. It shows, I think, there's still some work to be done on helping providers feel more ready and capable with value-based purchasing. And this slide on the left, you can see how providers felt about their organizational experience with VBP, and on the right, their clinicians' experience. Generally, a lot felt neutral. On the left, you can see organizationally, perhaps more felt positively than on the clinician level. We also got some comments from providers on how they experienced VBP. And on the positive side, they appreciate the focus on value instead of volume and the ability to put more resources into quality improvement. But on the negative side, we did get some comments that people could find it challenging to deal with all the different payers and different types of VBP programs. They also identified some struggles to having access to timely data. And several providers also noted that it seemed like there were minimal financial reward for the administrative burden of participating in VBP. Similarly to the payers, these are the top enablers and barriers for providers. And you can see they're listed in order of the number of respondents who identified those as enablers or barriers. And at the top for enablers, you can see aligned quality measurements and definitions, trusted partnerships, access to comprehensive data among the top 5. And on the right, top barriers, misaligned incentives, lack of timely cost data to assist with financial management, and lack of interoperable data systems among the top barriers. On the left here, you have the perceived role clarity, or for both, you have the perceived role clarity of HCA, payers, ACHs, and providers in VBP. On the left are overall results, and on the right is the results specific to Greater Columbia. And they're fairly similar, and you do see quite a few providers find it either somewhat or not so clear in the way they perceive the role clarity. So again, I think this shows there's an opportunity to improve on that with our providers and VBP. We asked providers whether they collect data, that's the first column on race, ethnicity, and language, and on the right, do they assess performance based on that data? And the majority of respondents said they did collect data on race, ethnicity, and quite a few also said that they assessed performance, particularly compared to last year, where we only had about 80 providers who collected this type of data. and only about 20 who assessed performance on this type of data. We also asked if organizations implemented programs to address health disparities by race, ethnicity, and language, and 68 did, and another 61 said no, but that they addressed other aspects of health disparities. And again, that's a really big increase from last year, where only 34 providers said that they were addressing disparities by race, ethnicity, or language. This slide is specific to Greater Columbia. On the left, what type of technical support has your organization received? And on the right, what type would be most helpful? And here it looks like there might be an opportunity in that 10 of the providers who responded to the question on the right said that it would be helpful to receive more technical support on value-based reimbursement. And the second highest category, I guess, would be practice transformation on the right there. And we did ask questions on COVID for providers as well. So has COVID affected your practice's ability or capacity in these ways? And many, as you might expect, many providers said that they experienced a challenge to the sustainability of normal business operations. The overall results are on the left, and Greater Columbia's results are on the right, and they're fairly similar between the two. And we also asked how payers, purchasers, and providers could adjust their VBP strategies in light of COVID. Greater Columbia results are on the right, and overall results are on the left. Quite a few indicated that it would be helpful to pause the expansion of VBP. That's the purple section. And also quite a few said that it would be helpful to reduce or limit risk-based payment models until the pandemic is over. That's the blue section. So I know we walked through some of those slides pretty quickly. Do any of you have any questions or comments for us about the information we've shared, or perhaps information that you wish we had shared?
Hey, Chelsea, this is Patrick. We've got at least 5 minutes for questions from the floor for JD and Mia. I don't see any in the chat box. Do you see any?
I do not.
All right. I know that there was a question from ACH staff, so maybe we want to start there. And Carol Moser, I didn't see your name pop up, but I imagine you're there. I think you had a question, did you not?
Well, no, I thought maybe one of my first comments, thanks Patrick for asking, is just, I think JD mentioned that it looked like there was opportunity to talk to the MCOs and the ACHs about what we could do to increase the level of value-based payment contracts in our region. So hence the need for these kinds of meetings to hear from our provider organizations who might have some really good suggestions on that. But I was glad to see the data is validating what we have seen, which is the ability of some of the MCOs to go into contract with, our smaller organizations because of the volume question. And I guess that would be maybe a place to start is, what does healthcare authority consider as a volume in order to be able to have that level of population that would make it affordable for an MCO to go into that kind of a contracting arrangement? Because that seems to be the biggest issue in our region, is what we've been hearing from our MCOs is that volume question.
JD or Mia?
So, yeah, happy to take that. So, I mean, we don't have any analysis, or I don't feel like we're in the position to say that a provider needs X number of covered lives or X amount of revenue in order to participate. We believe that there are flexibilities within the APM framework such that smaller providers with fewer patients or less revenue can participate in some VBP. Obviously, global budgets, full capitation isn't going to make sense for everybody, but we believe, things like rewards payments for performance, a category 2C payment, is a viable option for small providers. Now, that's a decision that's going to have to be made between the MCOs and the providers. So, we there's a line where, our role ends. We've set the direction with the contract requirements. We look for opportunities to provide technical support, but we can't get in the middle of negotiations unless it's a mandatory model that we implement. So I think there are some reasonable strategic decisions that the managed care plans have made to, focus on larger provider systems at the outset. Those systems tend to be more ready and have kind of internal capacity and capabilities that a lot of smaller providers may not have, and then over time bring in those smaller providers. So I think the most detailed responses would have to come from the plans and providers in your communities. But we do believe that there is opportunity for most providers out there.
Great.
Good.
Thank you.
We will be asking that question of the MCOs coming up here, so we'll have a second crack at it. So Chelsea, you just posted a question that came from the floor. Mia or JD, would you like to take a crack at that?
Let me see if I can see it here. Which question am I looking at? Sorry, I have to scroll through the tiny window here.
Okay, I'll just read it to you. It says, can you clarify how you assess access? In a rural community, moving cares to centers of excellence can feel like restricting access by moving care far away.
Yeah, this is a great question. And actually, in the roadmap, we highlight that the first thing we need to do is develop methods to measure that access. Both to provider types, but also service types. So a lot of that is to be determined, but we know it's something that's important and something we need to focus on.
Okay. Next question from the floor, maybe the last question, but if there's another question, keep it coming. We're just about on time. Here goes. 2019 was a big year for fully integrated managed care. Lots of new models in the GCACH region. Did this have an impact on the percentage of value-based payment models in our region? Did the fully integrated care impact the adoption process, I guess?
Yeah, I haven't done that level of investigation yet. I just got this data this week, so it's been kind of a whirlwind of putting it together. But I intend to do some analysis to see what the trends have been in regions as they've moved to integrated managed care. So more to come on that. I did want to jump back to the previous question real quick. I noticed I didn't address the centers of excellence portion of that. And fully hear you that COEs can feel like restricting access. And that is, so just to clarify, the COEs we've implemented are only in our employee benefits side, and not that access isn't a challenge to that population, but we understand that specifically in Medicaid, COEs just, they don't have the same, I guess, value maybe. I don't know how to put that appropriately, but one of the big things is travel, and can you expect Medicaid members to have access to transportation in the same way as an employee might? Maybe not. Does that make sense? So we haven't gone down the road of implementing or developing centers of excellence within Medicaid. But even in the employee side, there are challenges based on where someone lives and having access to those centers of excellence. And so we've tried to kind of amend those models or implement things that connect regional primary care or outpatient, therapy to allow someone to maybe go to the center for the surgery, but then go back to their place of residence to get their ongoing care. So just a quick note there, but good question and definitely a valid perspective.
Well, very good. Thank you so much, JD and Mia, for that thorough and quick presentation. You're welcome to stay with us throughout the rest of the presentations, and I hope that would be a learning experience for you to hear what's coming from the field. But if you're busy and you have to go, we understand. The next group of folks presenting will be our provider panel. And as you can see here, we've got quite a mix. Penny Bell from Ideal Balance, Shane McGuire from our own Columbia County Health System, Dr. Michael Shannon from Physicians of Southwest Washington, and also our own Kevin Martin, Dr. Kevin Martin, Medical Director of Kittitas Valley Healthcare. So we will take all of you four in turn, just the way you're listed in your cameo snapshots on the screen. And again, if you would keep your remarks to 6 to 7 minutes so that we can have ample time for a robust Q&A at the end. And so I would ask folks who have questions of each panelist to type it in the chat box, and if it's directed specifically to one person, please make a note of that. With that, Penny, the floor is yours. Penny, are you there? And if you're there, perhaps are you muted?
Okay, yeah, so I'm unmuted now. But yeah, this is Penny Bell with Ideal Balance and Ideal Option. I run a outpatient SUD facility, and I am co-located within Ideal Options MAT clinic, a medical clinic, in multiple locations across Washington State. And this is a huge topic that I'm, getting ready to address. I was sent 3 questions to answer. The first one was, what are the barriers to value-based contracting from my perspective? So when I speak, this is what I have experienced with Ideal Balance. And although we're starting with something negative, there are some positives that have happened, but I've been asked to speak to the barriers. The greatest barrier I've seen so far is the lack of engagement or communication from the payers. We have invested, as providers have invested a lot of time and energy into preparing for going forward with value-based contracting. But it feels like we're stuck in the preparation stage and not knowing the outcome, which is, what does the money actually look like? And I say that because obviously this is an expensive endeavor that we've started, and we want to be able to, see that we're going to be able to maintain all the programs and whatnot that we have implemented to meet the requirements for value-based contracting. Another barrier, currently, the medical monies for Medicaid are a lot different than the behavioral health dollars. So under Medicaid medical, typically the medical providers are, paid the same price for every service, no matter where they do it, by all the payers, the same amount. With behavioral health, the reimbursement model is extremely variable. It isn't just by payer, it's also by location. So the same payer will pay one rate in Benton County and a different rate in Yakima County. So it's what would that look like if we could go to, are all the payers going to be on board with the same reimbursement model, basically, what the funds would look like. The outcome measures is another barrier. We're tracking so many outcome measures under the ACH. We look at the HCA dashboard, so we're meeting a bunch of the milestones and looking at it. But again, the payers, we haven't had any conversation with the payers on what exactly do they want to see and what would that look like for a value-based contract. Let's see, the next one was my question. This is more of a question, not a barrier. I feel like I'm waiting for the payers to come to me to get ready to contract with them for value-based contracting. And I'm getting ready to actually develop a proposal to go to the payers and say, I'm ready, let's get moving on it. And I don't feel like there's just been a lot of communication, even though we've learned a lot. There's not been anything, we've just hit a stop. And not just COVID, because we started with the managed care organizations, years ago now. So I think we should be further along with that. The next question is, how has practice transformation helped me prepare for value-based payments? the general answer is, what haven't they helped us with? They are unbelievably helpful, given us so much education, all the meetings they've had to have, professionals come in and teach us what value-based contracting even looks like. They had Adam Falcone come in, who was a negotiator for contracting, so that was really helpful. There's so many. They've allowed us, the funds have been really great for switching to a certified EMR, which a lot of behavioral health providers we didn't have previously, and that was very expensive. We got the funding for platforms and programs that we've implemented to be able to improve the quality of our care while also tracking all of the data that we are collecting. So it's the collecting the data, the tracking of it, the quality improvement programs, everything that we're doing has been quite expensive, and typically SUD reimbursement rates don't afford a lot of extra money after you pay your bill. So having the dollars from the ACH has been great. It's been unbelievable. And the education, and they're always there for us if we have a question, and they put things together that we say we don't know about this, and then they get a meeting together, like this meeting today. This has been really good. The last question we were asked was, how do you pay for care coordination? This one kind of confused me a little bit. When I look at care coordination, that is anything under a case management. And currently we have the ability to bill the payers for case management, so we can provide that. This was probably more a question for a medical provider, not a behavioral health provider. But I think that the number one deal is, what is the payment going to look like? So we have prepared and prepared and prepared without knowing what the end result looks like. And it makes it very difficult we've invested so much time, money to do the right thing. These are great things we're implementing, but to not have a clue on what it looks like when we can show to the payers that we are providing, value of care to their enrollees. So, and that's all I had on mine. So if you have any questions, let me know.
Okay, so thank you so much, Penny. You're very much on time, and I hope there will be questions for you at the end of Dr. Martin's presentation. Shane McGuire, you're up next. Can you give us the perspective to these three questions from a health system? Shane, are you there?
Rural health clinic. Hi, can you hear me now?
We can hear you.
Hi. Perfect. Hi, this is Shane McGuire. I'm with Columbia County Health System. We're a public hospital district. We have a critical access hospital, 2 rural health clinics. Our clinics are integrated models of care. We do have behavioral health specialists working alongside our primary care doctors, and we do contract with the University of Washington Ames Center to have access to the psychiatrists and the team there for behavioral health integration. What are the barriers to value-based contracting? I want to start off with saying that there are a lot of positives. We've been in an ACO for 5 years. We participated with the ACH since inception. We believe that population health addresses very important issues. We completely believe in the model. And so from a positive perspective, we've embraced it. We've built a lot of infrastructure. We've worked really closely with the ACH to build rostering, IT integration, those types of things. I think the largest barrier that we see most of the time, for one, is our population. The average age of Columbia County, for example, is 50 years old. 27% of the population is over 65. It's a lot of chronic disease and comorbidities within that population. It's not an attractive necessarily population from a risk perspective. The other barrier we have is unique to us is that we span 2 different counties. Waitsburg is actually in Walla Walla County. Columbia County obviously is in Columbia County. And I saw a slide earlier that made a reference to the Medicare Advantage plans, and a great example of some of the frustrations we have is Medicare Advantage plans are offered in Walla Walla County. We have residents in Waitsburg that sign up for Medicare Advantage plans, and they come and see us. We cannot get Medicare Advantage to actually contract with us. And so what happens is we consume a much larger contractual for those patients, if not provide the service for free. to maintain the care of those individuals, but yet not be able to actually participate with a Medicare Advantage provider. The other thing that we noticed specifically along the lines of misaligned incentives, we have contracted with ALTC for numerous projects. We provide their foot care. We have an ALTC nurse that works with complex cases in the home. We've seen very good statistics out of ALTC that these programs do save money, but in actuality, it doesn't actually cover the cost of care to provide those services in our community. So the resources we spend to provide those services less than the reimbursement we get from ALTC for doing them, while ALTC and other payers are the beneficiary of the cost savings. We actually see that in many places. Many of the services that we provide, such as palliative care, doesn't have a real concise reimbursement model. And so what happens is you provide very, very in-depth care coordination for these individuals. You do reduce the total services that they use within your community, which sometimes means a reduction in ER services and other services that have clear reimbursement methodologies, whereas palliative care and some of the care coordination community health worker services do not have a clear reimbursement. And so we're trading clear reimbursement methods for methods and services that we know are better, that we're going to continue investing in and providing in, but actually hurt our overall bottom line by doing better care coordination. You had suggested the practice transformation, how it's helped you. I mean, we've been doing practice transformation for almost 6 years. It's reshaped our entire workflow. It's reshaped how we look at our patients. It's definitely reshaped our analytics and IT infrastructure so that we can better track patient by roster or patient by disease state. And then lastly, how do we pay for care coordination? If we are capable of getting CCM chronic care management visits billed, then we do. The methodology to get a successful CCM visit billed is very complex. It requires complex coding, charting, keeping track of time. The coders have to be able to parse through complex multi-provider notes in order to get the bill out correctly and get reimbursement. It's very, very challenging. Again, on the lines of our community health workers, they do a tremendous amount of care coordination, and there is no reimbursement strategy for that level of coordination. And then lastly, I would say that most of the specialties that I would say all of the specialties that our patients use are outside of our organization. We do not have any specialties on site. And so the majority of our cost per beneficiary ends up being on the specialist side. And it's been nearly impossible to even get them to communicate with us about any kind of VBP agreement or contracts for those patients. And so, you know, many challenges, challenges in the demographic, challenges in the size and the number of patients. We have not necessarily been approached by any of the payers to get involved with any of the VBP contracts that they have. And so we've had to look outside to larger group affiliation in order to sort of be able to participate. So ACO is a great example where we're a member of a very large ACO that has 100,000 lives in it, that's made up of multiple care providers. For us, it ends up diluting the incentive down quite a bit. Plus, we have the membership overhead that we have attached to it. And so lots of positives, but lots of struggles, and we still do not see a clear path to how shared savings and contracting can actually benefit us for some of the things that we're doing and the hard work these people are doing here. Thank you for your time.
Thank you, Shane. And I hope the MCOs on the line will be able to respond so far to both Penny's comments and Shane's comments that we've heard about that relationship. So third up is Dr. Michael Shannon from Physicians of Southwest Washington. And the floor is yours, Dr. Shannon.
Perfect. How am I doing for Audible?
You're doing fine.
Perfect. Thanks. So PSW is a population health company based in Olympia. We have a couple of Medicare Advantage plans, a Medicare ACO in 3 states, and several commercial lines of business. And we serve as the hub of an IPA for a couple hundred independent providers, and we have a health system minority shareholder as well. And when looking at the barriers to value-based contracting from our perspective, some of these are going to be echoes of what Mr. Fisher and Ms. Nafziger presented earlier. One of ours is definitely the long lag time for claims data and some quality data. It can be months. I just presented to our governing group. This is late November. I presented the data we have for one of our plans through June. So it certainly delays our ability to enact timely interventions. It also is a major source of provider abrasion when we give them a list of gaps that they have, and they end up sending in a note that says 23 of these have already been done. Partial lack of healthcare IT interoperability is part of it as well. We have a few hundred doctors, but they're on 20 or 30 different EHRs. That can either require a lot of IT trying to create some sort of central switchboard, or it can create a lot of work when you have to do manual extraction. And the last barrier, and this is more of an issue in Medicare ACO, but it sounds like some of my colleagues on this have had similar challenges, is in attribution and alignment. In Medicare ACO is we could invest a lot in a patient, and it turns out they see somebody one visit more than us in a different system, and then they are attributed to them. For the part of practice transformation preparing us for value-based care, we had already designed our provider payment, especially for PCPs, with substantial incentives if they both hit key quality metrics and also achieve utilization goals. So in our Medicare Advantage space and several of our risk contracts, we were already used to incentivizing them for this as we did the practice transformation. So and they've been very comfortable moving along, and over time, just as the guidelines change and what the government likes to measure changes, we just have to update those. We have a strong central care management team, so they rely on our central hub to do most of the care management, and that's been part of the role for them as we provide the coordination between the members of the appointments, and we do remote patient monitoring and some nurse triage. And the last, we invested in Innovator, although there's certainly other groups as well that are healthcare IT tools. So we finally put enough money in to be able to get reasonably actionable claims, close quality gaps, and improve what's appropriate HCC scoring. In terms of how to pay for care coordination, we run all that centrally. Our providers and contracts rely on us to do that. So usually we're either going to be the hub of the contract for Medicare Advantage, and we will just insource the cost. Or if we're doing something like a management service deal, where right now we're supporting care management for a group in New York, we would just charge them a per member per month. We do sometimes carve out areas where we lack highly specialized care managers. So we will, for instance, carve out and outsource transplant, some behavioral health, and some end-stage renal disease. So that's a look at how we've handled that at the PSW end. Thanks.
Okay, well, that was short and sweet, Dr. Shannon. You have a bit more time if you want to take a couple more minutes, or if you just want to wait till the Q&A, that's fine too.
Well, just a couple of sentences. I did enjoy the presentation from Mr. Fisher, Ms. Naziger. We see similar. It's good to see that actually what we see as challenges, and also from Ms. Bill and Mr. McGuire, is what we see as similar changes, which is make it interoperable. The only thing, again, we've emphasized is the data lags have been a bigger issue for us than other people have mentioned. Just the ability to find out that 4 months later, that people have been missing certain quality metrics or have had a wave of claims that we haven't picked up on can be a struggle. So that's the only part that I'd emphasize that we've had that I guess others have had less trouble with.
Okay, very good. Thank you. Okay, last certainly not least, and certainly not least, is Dr. Kevin Martin from Ellensburg, who's been a part of the Greater Columbia ACH almost from the beginning. So welcome, Dr. Kevin, and the floor is yours.
Good morning. I'm Kevin Martin. I'm the Chief Medical Officer for Kittitas Valley Healthcare. As I've been listening to this, I'm reminded of a healthcare summit that took place October 13th, 2009 at Seattle Center, and involved 50 representatives of payers, 50 providers, and 50 employers, ranging in size from the state of Washington down to a mom and pop machine shop in Tacoma. And what we were there to discuss was, what should a patient-centered medical home look like? What should practice transformation accomplish? And the morning session was a robust conversation with 3 large breakouts, and all 3 groups came up with the idea that a patient-centered medical home ought to offer the services that patients need in one place, and that it absolutely had to include integrated behavioral health. The afternoon session was focused on how do we pay for care coordination and how do we pay for patient-centered medical home vice president for a large payer, started the conversation by saying, right now, primary care costs me $25 per member per month, and anything that costs me a penny more is a non-starter. So it's interesting that 11 years later, we're having almost precisely the same conversation. In terms of barriers, I could just echo everything that's been said, although I guess one of the barriers that I perceive that we don't recognize is we tend to talk a lot about expecting practice transformation to result in meaningful transformation and meaningful outcomes. And we forget that in a patient-centric model, the meaningful outcome is the one that matters to the patient. And we lose that in our discussions of economics and efficiencies. One of the barriers is that, to the extent that PCMH and practice transformation is supposed to result in savings by being more efficient. If we are having to go back and have retrain providers to diligently make sure that they hit the right check boxes in order to capture the efficiency, we're done. We've shot ourselves in the foot. We have to rethink that. We have to be getting past a CPT-based model, a coding model, that we're putting a new body on fee-for-service at that point, and we're losing the efficiencies that we hope to achieve. As an organization, I can't tell my providers that they have to meet the different requirements of 5 different payers in order to achieve a quality metric. We have to be able to design our systems and have the payers recognize the value. And it has to be the same system for every payer. We have recently severed relationships with one large payer because every quarter they would sit down with my quality officer, my CEO, me, my CNO, and they would outline for us all of our gaps in care and tell us that if we met those gaps, we could get paid an extra $17,000 a year, and that we were talking about 1,700 covered lives. And failing to recognize that we were probably spending as much on room space and expertise as we're hoping to realize from the improvement. Practice transformation, how has that helped us? Part of the backbone is the idea that you've got your metrics in a central EHR, and it gives you access to data so that you can look at the care that you're giving and improve your quality. What has been the biggest barrier to now is the fact that absolutely nobody is paid for it. And GCACH, with the support of the practice transformation navigators, with IT support, has really made practice transformation accessible to our system for the first time ever. And I'll just point out that my predecessor as CMO here used to co-chair the Washington Academy of Family Physicians Practice Transformation Work Group with me going back to 2004. So this organization has had a long focus on practice transformation, and it simply hasn't been attainable until now. With the support of ACH, we have one clinic that has successfully implemented the AIMS PCMH model. We're looking to spread that to our other 4 primary care clinics. It kind of is the end of 11 years of frustration to see that coming to pass. The third question we were asked to address, how do we get paid for care coordination? I'll let you know when we do. Right now, like Mr. McGuire was saying, we treat it as the cost of doing business. We have to take care of our patients. We have to make sure that they get where they need to be. We have to do everything we can to make sure that that care is available here. I have patients that will tell me that from November to April, Yakima is inaccessible, never mind Seattle. So care coordination is a challenge, and we have had some conversations with with the Kittitas County Health Network as to how they can take on a care coordination role, and we've had some fascinating conversations with Molina about what that might mean for them. But that's still very much a work in progress. I think that's what I've got. We've got time for questions.
Okay, so we definitely have time for questions. We got a good 10 minutes, or even slightly longer. Chelsea, do we have any questions in the chat box? Okay. Well, I'll just pose a question to all four of you, and if you could respond to this, if it's possible, and maybe this will spur some other questions. We saw from JD that the roadmap from the HCA really has 2021. I think it was with 90% of the transactions being based in nature. And I just wanted to get a sense from the four of you if you think that is going to be a reasonable goal for each of your organizations, that 90% threshold.
So this is Michael, Shannon speaking. We actually only sign contracts that include value-based because if there is no value component, we really don't know what value we'd add to our independent shareholders. What we're finding is certainly greater amounts of upside downside risk available to it. But at this point, we would only look at those. And as we get our foot into other contracts with commercial and Medicaid spaces, we only look for those that have significant risk for us, and we feel comfortable taking that. So it's probably 100% for us just because of what we take.
Okay. Okay. Anybody else wants to weigh in?
Hi, this is Shane.
Yeah, Shane.
This is Shane McGuire. I mean, currently the only methodologies that we have for any kind of value-based component is through partnership like ACO, and while strictly not a value-based agreement directly between our hospital and a provider such as Medicare, it is an indirect value-based agreement that does have a shared savings component. 55% of our population is Medicare here, but I don't know that we're actually getting sort of the attribution to say that that's a VBP contract because of how we're approaching it, which again takes me back to the biggest concern I have is that there really aren't payers lined up to sign value-based purchasing agreements with Columbia County Health System. And if they do have them, they are challenged by the fact that we have multiple counties. For whatever reason, our payers sometimes divide themselves by counties. And so we're in both Walla Walla and Columbia County. And so we'd have to have payers that are willing to sign agreements for both service areas. So I personally think it's a concern. But having said that, only 20% of the population lives in rural anyway. 80% of the population of the state lives in urban centers. And so they may still be able to hit their goal, but still exclude rural. And that's of a huge concern to me.
Okay. And Greater Columbia ACH is definitely a strongly rural area, obviously with some metro areas that have some population centers to them, but this is one of the more rural areas of the state. Anybody else wants to weigh in on that question?
Yeah, I'll echo what Shane was saying about the challenges of rural and Greater Columbia. And up in our tip of Greater Columbia, we sometimes feel like anything east of the Cascades is invisible from Seattle, and anything west of the Columbia is invisible from Spokane. If we can get to 90% VPM and it appropriately rewards the changes that matter to quality, the things that don't take place in the exam room necessarily, yeah, I think it's realistic. But the devil's in the details. HMOs were a great idea, but wound up adding to cost, not saving money. It's got to be, we have to be able to capture the benefits that we accrue from better care if we're going to pay for less care. And that really often is better care. I mean, when you're talking about the lack of efficiencies, the exorbitant costs we have, it's provision of unnecessary care and how we pay for it. I think BPM has a lot of promise, but it's only a promise.
Okay, thank you. Do you have any thoughts on that, or should we move on?
What everybody said is accurate. Definitely, it's, you know, at this point, I feel like I'm just sitting and waiting for payers to come to me and say, okay, what's going to be put on the table? And I don't feel like they're anywhere near that yet. But to be able, like, but it's very costly to provide less quality care, less care, but higher quality. And it's how are those costs going to be, you know, covered? Under our current models, obviously they're not. So you do a lot of services that are free in hopes that what you're getting currently can cover that. But I agree with everybody else.
Okay. So we had one question, it looks like in the chat box addressed to Dr. Martin, and apparently that's been answered. Thank you, Kevin. Let me see if
I do want to add one thing to that answer, which is
okay,
just
go ahead.
thank you GCACH for their support in helping develop the Health Commons. We can see where that's going to be a massively useful tool for us, and will allow us to. What we're using it for now is to coordinate care around people who've fallen through the safety net. Folks who really, frankly, aren't contributing to hospital costs because they have no way to get to the hospital. A lot of folks that are homeless or at least severely housing insecure, that we're able to get out and touch and improve their lives. That work, we're hoping, and this is kind of the conversations we're having with Molina, if we can expand that from taking care of a few dozen people to a few hundred people. And that's incredibly exciting, and we wouldn't be having this conversation without the support of GCACH, so thank you.
Okay, very good. I'd like to follow up on a comment that Dr. Shannon made and see whether others have some thoughts, and perhaps Dr. Shannon has his own thoughts on this, but you indicated that one of the real challenges that you've seen is this long lag in data reporting that is supposed to be a sort of the basis for a feedback loop between patients, payers, and providers. And do you have any thoughts? Do any of you have any thoughts on how that data lag might become shorter?
Yes.
All right.
The reason for the data lag is because we're using claims-based data. And so I provide a service, I submit a bill, it gets processed, the patient gets an EOB, hopefully I get a check, and the data goes into a repository. The payer who took care of the claim compiles the data. They have to allow adequate time to make sure that the claims for the last quarter have cleared. So 2 or 3 quarters later, we sit down and discuss history. On the other hand, if we were to base the analysis of the care that my providers are giving by what's documented in the EHR, we now have access to near real-time data. The problem we've run into is that the payers that have offered us that feedback do it from the perspective of their lives, not all of the lives that we care for. And quite frankly, I'm not interested in improving the quality of care for the patients of a given payer. The care should be payer agnostic. I'm interested in data about the quality of care my providers deliver. And that's why I've got a quality department, because I can get real-time data out of my own system. I can't rely on the kind of data that policy is based on.
Okay.
This is Michael. The challenge.
This is Shane.
Go ahead, Shane.
Well, let's go with Dr. Shannon first, and then Shane, you're next.
Well, I'll be curious for Shane's thoughts on this. So I sympathize and like everything Dr. Martin had to say about this. The challenge is our payers who are giving us value-based payments, frankly, could care less what's in our EHRs of our providers, and we just have to send it to them in some form of claims form. So there's educating people about CPT2 codes. And then, for instance, even if they have everyone on a statin, and I can prove they're on a statin if we didn't get the right code in there for this. And the biggest challenge has been on the claims portion of these is going out and telling, going to our big clinics and saying, hey, these are your 42 different gaps we need to close. And then the next day getting a list showing that 26 of those were already done in the last 2 months, and then getting a barrel full of why we're not up to date on this, and trying to educate providers that there will be a lag. It's better than it used to be. But that's been our biggest frustration for this, is getting everything into claims form, no matter what's in the EHR, and educating providers about why, and then trying to close the time gap so that we don't end up making providers rework things they've already done. Thanks.
Okay, thank you. Shane?
Yeah, so I'm going to echo a couple of things, sort of with a small rule, ultra small rule caveat. We learned early on with the ACO that relying on claims data and ACO data was not going to be effective. And to Dr. Martin's point, it's just reviewing history way past the time where it could have been helpful or effective, even for program success. When you're getting Q4 data in Q2 of the following year, it's very difficult to pivot and make changes. And so we really built a robust analytics team internally, and we're learning every day how to use our own data. I also echo the frustration about reporting based off a payer population versus reporting and looking at things as an aggregate. Why should Medicare beneficiaries have a different service offering than Medicaid beneficiaries and commercial beneficiaries? And so we really have streamlined our practice to sort of provide the same level of care across all payer mixes, and then have our analytics team deal with the frustration of breaking out who needs what piece of data on how we cared for that patient. And then lastly, in a small rural environment, anytime you aggregate us together, you get these really nonsensical, useless reports where they say, hey, here's your quality metric. You need to do smoking cessation education for your Medicare beneficiaries. And then you get a report at the end of the year saying, congratulations, 100% of your Medicare beneficiaries received smoking cessation education. The problem is at the end was drilled down to one patient for our entire service area, because they only needed one patient based off of the size of our aggregate population in the context of this much bigger ACO population. And so my people look around the table and they said, well, it could have just have been as easily as 100% of your patients didn't get the education, depending on the random patient that they chose. And it doesn't feel meaningful. At that point, it doesn't feel meaningful. And so we have to sit through some of these steering team meetings with ACOs and ACHs sometimes, and then we look at our actual data and say, no, 65% of our population got smoking cessation. Just to keep it relevant, if you're going to try to base your successes completely off the these program elements, it can become quite frustrating and disheartening, actually.
Thank you. That was very helpful. Kelsey, any other questions that you're seeing in the chat box? We've just got
not that I'm seeing on my end.
Okay, we've just got a couple of minutes, and I'll just throw it open to the panelists then, and say, do you have questions of each other from the presentations you heard from the four of you? Apparently not. So then I hope you will all stick around for the final panel where the four of the MCOs will be presenting. And I would hope that all of you folks representing the MCOs have been able to listen to the comments from these four folks, and would be able to provide some response in the course of your remarks, or perhaps in the discussion that will take place afterwards. So with that, let's give a virtual applause. Penny Bill, Shane McGuire, Dr. Shannon, and Dr. Martin. And we'll be back in 10 minutes. We're running just a couple of minutes ahead of schedule. So congratulations, and we'll see you shortly. Hello, everyone. It is halfway to 11 o'clock and we are on to our final panel. And as you've seen in the agenda, this will be many representatives from our managed care organizations in the state. And just to quickly go over them, Caitlin Safford, Aaron Hafer, I hope I got that pronunciation right, Aaron, Edie Dibble, Kate Mundell, Tony Gildred, and finally Heidi Nelson and Whitney Howard, representing in order AmeriGroup, Community Health Plan of Washington, Coordinated Care, and Molina. So the order we have is the way the Cameo thumbnails are presented in the page you're seeing on your screen. And again, like we have asked the prior panel, we've sent out 3 questions to respond to. And I know this is a big challenge, guys, but trying to wrap those 3 questions, the answers to those 3 questions in 6 to 7 minutes, so we can have ample time for Q&A at the end. And I would give you, if you want to take it right now, also a couple of minutes each, if you would like to respond to some of the comments you heard from our provider panel. So with that, Caitlin, the floor is yours. I will say that I'm missing seeing Caitlin in person, because at this time of the year in the past, Caitlin has always brought Christmas cookies to this kind of a gathering, and she's a very good baker. So sorry we're going to miss those this year, Caitlin. Go ahead.
Thanks, Patrick. That's so nice. I miss seeing all of your faces. I feel like I haven't been out there because I was pregnant at the end of last year for a very long time. So yeah, I can start us off. Just I'll try to go through. Would it be easiest to kind of give AmeriGroup's response to all of these questions, or do we take a question at a time going through all the MCOs? What works best?
No, I would like you to go to all of the questions, and then we'll double back and see if there's some commonality afterwards.
Okay, gotcha. That sounds great. So I think the only response I had to the provider panel, which I thought was really helpful, interesting to hear, especially the progression. I haven't heard a provider panel be really that honest about VVP in a couple years. So actually, it was really helpful to hear where people are at right now. I hear you on the claims and the data lag. I think some of our frustration, and has consistently been our frustration with value-based payment, and this is a nationwide problem, is that most of our metrics that we're held to are claims-based metrics, and they're not as chart-based or quality of care, like really looking at the patient improvement of care as much as we would hope that they could. And so I'm hoping that will shift in the future, but we're all beholden to our quality organizations and agencies, and have to follow their requirements just as much. And that unfortunately does filter down to our providers. So that's just an overall infrastructure issue we have with value-based payment. But jumping into these questions, for AmeriGroup's perspective, we actually don't have any problem contracting with our small, rural, or BH providers related to value-based payment. It's just the manner of that model might be really variable, and the kind of model we may have with a primary care provider might look really different than a behavioral health provider, partially because, particularly in the greater Columbia region, I think we are the smallest MCO there. So we just don't have a lot of members. And so it's hard for us, and it's actually not necessarily very safe from a risk standpoint for smaller providers to take on any sort of risk for such a small population, because then the incentives and everything vary wildly when you have such a small population. It depends on if somebody can get in the door that 1 month, whether or not you get an incentive payment. And that's not really what we want to encourage necessarily. So sometimes just straight up capitated contracts, while we try to build up our incentives and monitoring quality of care, is really where we like to start. Additionally, I think we are really interested in starting to test out how we help providers move along the spectrum of integrated care. So that's actually what we're looking forward to in 2021 and 2022, what it's like to build incentives into our contracts with both behavioral health providers and primary care providers, regardless of size, incentives to move along the continuum of integrated care. And how do we measure that progress? How do we validate that progress? If it's a self-attestation, that's really what we're looking at. And I think that might be a great entry point, especially for the smaller providers and BH providers, to move into some sort of value-based model and start to build up the skills needed, which I know in Greater Columbia, you all have been working so closely with practice transformation that many providers have already built up those skills. So I think progressing quickly actually might happen. It could be a really good test case for our AmeriGroup while we're trying to build out this model of payment. For us, what we see is the ACH's role in VVP, and have since the beginning, is really trying to support the providers in building up those skills. For us, Greater Columbia is actually one of the best examples of having done this. Not every ACH focuses on practice transformation, and they don't necessarily do it in a consistent way or format with all of the providers, and really trying to make sure every provider is engaged, but then also tailoring to those providers' needs. So it's just not happening on like a ground level technical assistance in every region. So for us, Greater Columbia is actually a fantastic representation of what we were hoping ACHs would help with. So we are really appreciative of that. I think going forward, one thing that we would have liked to see in the financial models for ACHs, and this hasn't really happened anywhere, is in trying to pay on the waiver incentives, if we can try to figure out how to get providers used to also being the ones to contract for health improvement. So like if we have a value-based agreement, say with a primary care provider, and we've given them a little bit of risk, or they have, you know, significant incentives to improve upon certain quality metrics, then they're also incentivized to try to figure out how to help mitigate some of those social determinants of health aspects that might be affecting their patients' quality of life and care. So what does it mean for them to contract with a community-based organization to help with that versus the MCO also contracting with that CBO and then trying to make the connections between the provider and CBO. So really trying to build up that payment infrastructure for a provider to have those relationships. That's kind of what we would like to see. Thank you. 2 minutes. Oh, that was so helpful. You guys are so great. So I'll move on to the next question. How do the MCOs reconcile their care coordination versus the state care coordination program? Oh, this is always the biggest topic, right? So we have, I think, a third of our 350-page contract with HCA right now is related to case management and care coordination. So we have significant requirements within our administration and within Medicaid regulations to do care coordination work with our member population. But that doesn't mean that we're not willing to work with our providers. Actually, AmeriGroup's preferred method to do this is actually through our providers. We know, especially our behavioral health providers, provide better case management services on the ground to their clients than probably we can ever do, but we like to help supplement that with the resources that we have. So we have even contracted with certain providers to provide additional funds to do that case management. So we're absolutely willing to do that. It just depends on the model of payment that you're in, what you foresee being able to use that money for, how it's billed, things like that. Always conversations that we have to have. Additionally, I think depending on the care coordination program through the state, we might be willing to contribute something else, or if there's like a centralized entity that we could help support. That's always a potentiality, but it's something that we just need to discuss. And I know that there's been lots of conversations about that and not a lot of movement as of yet. And then the last question, how do PCPs help compensate the BH provider for contributing to their achievement of certain metrics? So this is exactly the thing that we want to try to start testing out in our integration model. What we've heard, and not necessarily from Greater Columbia, but other regions, when a behavioral health agency has actually partnered in some sort of co-location model or shared services model with a primary care provider, the primary care provider is the one that gets the incentives for having improvement, and the BH provider doesn't necessarily get that same recognition or even the same financial compensation for the work that they actually provided. So we're trying to figure out an equitable way to ensure that finances are flowing to both agencies. This is going to significantly help with parity, but also the behavioral health infrastructure in our state is just so severely underfunded. We want to make sure that we're propping up our BH agencies as much as possible so they can be an equal partner in integration and in serving some of our most needy populations and most needed services that we have. So it's really important to us to try to figure out what that looks like, and we don't know exactly how we're going to implement that in a contract, and we need some willing providers to help test it out, but it's something that we're really interested in trying to find out how we can do as we're helping providers move along the continuum of integration. I'll stop there and hand it off to Aaron.
Okay, that was well done, Caitlin. Thank you so much, and we'll be able to circle back and hopefully see a lot of questions in the chat box for you and others. So, Aaron, is it Hafer or is it Heifer?
Hafer. Can you hear me okay?
Yeah, we can hear you, Aaron. So the floor is yours.
Great. Thank you so much. And thanks, Caitlin, for opening up for all of us. I'll try not to duplicate too much. So I'm Aaron Hafer, Vice President of Delivery and Health System Innovation with Community Health Plan of Washington and Community Health Network of Washington. We are a not-for-profit Medicaid managed care plan here in Washington. And so any savings that we see in our contracting efforts are reinvested back into local communities. Just by way of background, I would say, CHPW was founded in 1992 and has really been engaged in value-based care for over 20 years. We're a committed member of the Healthcare Payment Learning Action Network and have been since it was first launched, and have also received advanced APM designation by CMS. And then most recently, we've become part of a 7-state collaborative along with the Healthcare Authority for advancing health equity, and that is focused on developing value-based payment to address health disparities and improve equity. And for those of you who may have participated in the pre-collaborative value-based purchasing session earlier this week, I think some of Don Berwick's comments around, we need to do more than just focus on value-based contracting. In order to see the improvements and reduction in health disparities, we're really looking at larger systems changes. So I think that, is a good area for the ACH to continue to focus on as well. So to respond to the first question, in terms of contracting with small rural or behavioral health providers, as Caitlin said, we do have contracts with behavioral health providers and rural health care providers across the state of Washington, and really just believe it's about building a relationship between the MCO and the provider and having flexibility in terms of what that value-based contracting arrangement looks like. So, we support a range of models. It doesn't necessarily mean that all providers are going to want to or be able to engage in a full risk arrangement or a total cost of care arrangement. It could be anything from that full risk arrangement to pay for performance, gap closures, or other innovative models for very specific populations. For example, we're exploring value-based bundled payment for MAT for individuals experiencing homelessness right now, which is a very small population when it comes to members that we serve, but just thinking about how we can creatively work with our provider partners to develop a payment mechanism that's going to allow them to effectively outreach and engage with that population and focus on some of the shared outcomes that we'd like to see. In terms of the approach to that, again, we really think of this as a partnership between the provider and the MCO, work together to align incentives and develop shared goals, which would include identifying quality improvement areas and priority measures. Ideally, when we're engaging in that work, we're looking at focus areas providers already have so that it's not a one-off or separate from what you may be doing with other payers, because we know that can create administrative burden. And then also, I heard a lot of the challenges around tools and data. And as Caitlin said, we have that challenge of lag time and some of the measures being reliant on claims data. However, we continue just to work with our provider partners around providing tools and as close to real-time data as we can provide to inform some of our partnership and targeted approach there. In terms of the role for the ACH, I would emphasize some of the points that Caitlin's already made in terms of just doing a really great job with the practice transformation efforts. I think to the extent you can continue to create tools to support providers around population health management, measurement-based care, and how to advance integrated care partnerships will continue to be a strength in terms of how the ACH can support VBP. Also, I would just say the ACH could maybe help providers in continuing to elevate their value statements, and but ultimately the contracting would continue to be between the MCOs and the providers directly. In terms of care coordination, similarly, we really again, have many requirements related to care coordination, but want to look at how we can work with provider partners to really enhance the programs you already have in place and not duplicate those. So that could be that could mean delegation of care coordination activities, or it could just mean partnering really closely with our internal care coordination teams as well, or our transitions of care teams. So let's see if I've hit all of the questions here. And then in terms of the primary care and behavioral health partnership, part of our work has been really to look at what are those range of models that we can support, how can we work to bring partners together to share data so that, for example, if there's a large volume of shared patients between a primary care site and a behavioral health agency, can we work to support shared workflows and really work on developing that value statement for the behavioral health agency to really grow that potential of shared investment and shared savings across provider partners. So with that, I think I will stop there and hand it off to our next panelist.
Okay, we have actually three panelists. I don't know which ones of you from Coordinated Care are going to speak, but Edie, you're listed first, so I'll let you respond to that. Edie, are you there? So, is Kate or Tori available then, if Edie is not on the line?
Patrick, Edie just commented that it looks like we're having some audio difficulty with Edie.
Okay. Is that something you can fix, or she's going to have to fix, Chelsea?
Well, I'm trying to unmute her, but it looks like I think she's muted on her end.
Right.
It's not allowing it. I think she's going to have to do it from her end.
That's usually the case. So,
Edie, if you click on the phone icon, and I see Kate on, but I don't see her. It doesn't look like she has audio.
okay. Well, in the interim, why don't we let Chelsea, you and Edie try to work this out, and let's go on to Melina and hear from either Heidi or Whitney or both.
Hi, Patrick. This is Heidi. I'll start us off and then Whitney will follow up. So I'm the director of contracting for our physical health providers, and Whitney manages our behavioral health providers. So we've worked together as we've gone on this journey to bring an integrated VBPs into place. And our team, the physical health team, really started this about 4 years ago with standard suite of models that we've brought to providers really to try and meet them where they are on their value-based care journey. So our program is a collaborative approach. My team works with integrated primary care teams, and we negotiate models, metrics, and other aspects of our VBC really to align with where providers are and their priorities for quality and level of risk they're interested in taking. So it's I think, as Erin mentioned, we have many different models in place with providers around the state. We are very open to working with small rural providers and have done that. Most of those are models with very little risk, and that's fine. We just want to make sure we can meet a provider where they are and be able to help them with the data that we're able to provide as a standard part of our VBP program. Our program it's based on collaborating. So we provide monthly reports that include both cost, quality, and member-specific information that supports care management. We meet with our providers on a quarterly basis at minimum to not go over performance, but really to use the information to take action. And we want the information we provide to our groups to be able to be something they can use immediately. So we take their feedback on on how to develop our reports to make them more actionable. And we hear from providers all around the state that what we're doing really does help what they already have in place for how they want to care for their members. In terms of how we incorporate our healthcare services team into what a provider already is doing, I think, as Erin also mentioned, we're trying to not duplicate with members what providers are already doing. So we use our VBCs as an opportunity to review not only generally what's going on, but specific members and how we can more align our work with them. So I think that might be my best response for question 3. In terms of question 4, how do PCPs help compensate behavioral health providers? We've started our VBPs with our primary care providers. We very much support using the information that we have about how members are seeking care to be able to have that as a foundation for how providers can connect within the community and develop new and best practices for being able to manage these members across the continuum. And I think that's then where Whitney and her team are working with us to be able to build that out as really an additional part of how our VBPs can support what's going on in communities. So Whitney, is there anything else you want to add to that?
Yes, thank you, Heidi. You know, I was listening to the previous panel. I know Penny from Ideal Balance had shared, you know, not really understanding, or maybe something to the effect of, you know, the behavior or the MCOs really aren't, doesn't appear that they're really ready to sit down and work on the VBPs. And, you know, we are, you know, it's under construction, as Heidi was talking about. We're trying to accomplish the same collaborative approach and be able to accomplish the same outcome in terms of our ability to provide the right tools and the right reports and everything necessary for all of us to be successful. And we've made huge progress, and you know, we're continuing that work. I wanted to add on number 1, I know what's preventing the contracting with the small rural and behavioral health providers, and I would just say that for adding behavioral health providers, that is, I think, the only component that we're really looking to solve for, not just as it relates to VBCs, but the network itself, in terms of making sure that we have the sufficient access needed. You know, during this pandemic, we understand there's going to be a surge. We also, we adopted the models that the WHO had as our starting point, and you know, we've been in this for 2 years now, and we're trying to build the models to support growth and to support the ability to do VBPs, you know, with our already existing partnerships that we have. So lots of work's been going on. We're using the expertise from our physical health side to help influence how we move directionally with our behavioral health providers in this VBC space. So I just wanted to add, there's though we're not sitting down at the table, I want the providers, I want the community to know that there's quite a bit of work going on. And we are starting to get some that we're getting out the door, and very excited about what we have upcoming in 2021 and beyond related to VBCs.
And if I can also add, I skipped over the ACH's role. I think what the ACH is doing and can do to help providers not just understand data, but be able to take action focused on population health strategies and goals in the community. I think that's somewhere where the ACH is and can continue to help providers. I want to acknowledge Dr. Martin's concerns about the claims-based data that we're able to provide. That really is an issue for all of us, not just, I mean, it's not something we're going to be able as MCOs to be able to fix, and together figuring out how we can access more real-time data, what's in the community, and how we can incorporate that into action. I think that's something providers, the ACH and the MCOs can try and do together, because that really is the next frontier, making this data easy to access and as connected as possible. I think another huge area the ACH can help in is being able to help us all address connections to community-based organizations to address social determinants of health. That is foundational for members to be successful in their lives. The VBP healthcare information we have is just a part of it. So helping strengthen those connections to what's going on in the community that can support our members, that's another huge role the ACH has had and continue to have in helping us improve our VBP relationships.
Thank you, Heidi. Whitney, do you want to respond also to question number 2, or do you think that's been covered?
I think Heidi did a good job covering that for us. Thank you. Thank you, Heidi.
All right. Do we have coordinated care on the line, Chelsea?
Yeah, this is Edie. Can you hear me now?
We can. Thank you, Edie, for tuning in.
Thank you for your patience. Apparently my audio and I were having some struggles there. Well, not to duplicate what the team has said, but I'll go into a few details. Like most of the group said, there's nothing preventing coordinated care in contracting with small rural or behavioral health providers. We contract with, all sizes of providers from solo to large systems across the state, whether they're rural, urban, or wherever. That is not a barrier for us. With the value-based side of it, as the gals mentioned earlier, sometimes it does limit the ability of both provider and payer to enter into a more risk-type agreement because their membership can be much lower. But, we have a full range of value-based agreements all the way from pay for performance all the way to full risk. So we're happy to meet providers where they are in that spectrum. The ACH's role, like the other gals all said, I think the ACH does a good job and continue to support providers, help building the relationships, help building the knowledge of value-based arrangements, gap closure, practice transformation, those sorts of things, just continuing with the collaboration and communication. As far as care coordination, I think both providers and payers and MCOs all have different case management programs, coordination programs, and I think it's really working together on the communication and collaboration in efforts to hopefully we're not duplicating our programs, but more collaborating together or figuring out who's working with who on what needs and more of a partnership, a streamlined partnership, building that relationship and being transparent. We have piloted some behavioral health value-based arrangements in 2020 and learned a lot from them this year. It is much different than the physical health side. With the physical health side, primary care, it's much easier to attribute members and see the cost of care, quality of care, member attribution, and that sort of thing. Behavioral health is a little different because patients can see multiple behavioral health providers at the same time. But again, we did pilot a couple programs this last year and learned a lot from them and did find some things we need to improve on and kind of tweak for our 2021 program going forward. We do look to our community providers to tell us where they're at in that spectrum and their comfort and how they would like to move forward. We have some agreements with non-primary care or behavioral health providers that we've entered into as trials that they've brought into us to kind of work through. Our tools and data reporting, while we do have specific monthly reporting for, primary care, toolkits and that sort of thing to help with the member specifics, cost and quality for those groups, we can tweak different reports for certain pilots that we've done and are bringing on board to see how that will work for each other and kind of tweak as we go. But just look for providers to help communicate in what their needs are and then talking with our data and analytics team to see if that's something we can do. But we've been very creative and able to do and meet some of those provider needs as we've done these ad hoc pilots. Thank you.
Okay. Is there anybody else, Edie, from your shop that's going to comment, or is it you?
I think it is just me, but Tori and Kate, if either of you wanted to chime in, feel free.
Yeah, no, Edie is our subject matter expert here, so I'll defer to her.
Okay. All right. Well, we made it through this panel in unanticipated record time, and so we have opportunities for conversation and dialogue and questions. And I would encourage anybody who has a comment or a question to type it into the chat box, and we'll get it up there. Chelsea, I'm sure, will let us know. While that's hopefully taking place, I just wanted to pose to all of you who have presented, and JD, and to JD as well, if you're on the line still, and that is, it's a bit of a question from left field, I think, for the kind of a conversation we're having today, but nonetheless pretty different. I mean, pretty imperative to think about. And that is, if we believe the Robert Wood Johnson Foundation's breakdown of sort of causality and the logic model for what is behind good health, we know that clinical care is only a part of that. And in fact, according to the Robert Wood Johnson Foundation, it would be a small part of that. And the upstream factors, the social and economic determinants of health are even larger. And so my question to all of you from the MCOs and to JD, if you're still on the line, is where do the activities to address those social economic determinants of health fall into your organization's purview? I know that's kind of a loaded question, but anybody want to take a crack at it?
This is Caitlin. I can start. I think we at AmeriGroup C, we're responsible for our members' well-being, and that includes their social and emotional health as well. And we're doing things that, at least what we can do, to try to connect more services to our members or support community-based organizations that serve a lot of the Medicaid population. And that's sometimes through grants. It's mostly through grants, to be honest. It's been a challenge to figure out how to get Medicaid to pay for that. I think, we also have the third-party administrator for the Foundational Community Supports Program and supportive housing and supported employment. and that is showing real promise. It's one of, you know, a real standout program in the country. It's still the only one that's really existing, and so we're hopeful that that will be maintained past the end of the demonstration part of the waiver. And then we can all hopefully have Medicaid covering those services. But regardless, we think that that's extremely important for us, and we're interested in understanding how we can better support our providers in helping in that way as well. For instance, a lot of focus in our contract recently has been around how we coordinate better with jails and jail transitions, and what does it mean to get them access to services. And that's always been a tricky question, because detainees, when they enter jail, lose their Medicaid, and then how they get connected back on, and when we know that they have exited the system, has always been a challenge. So we're trying to develop better data connections so that we understand when they've left the system or are about to be leaving the system, and can get them connected into services. So we've been trying to reevaluate whether or not we have to contract with a provider to help provide those care coordination services that then can get them connected to social services to better support them upon reentry into community, and what that looks like. This is just an example, but we're really invested in trying to figure out better ways to support our members. It's just always a challenge and some fun with trying to figure out how to pay for it all.
Good, thank you, Caitlin. I suspect that would be a response from the other MCOs. Does anybody else have a comment to that question beyond what Caitlin said?
This is Erin. I think the only thing, Caitlin said it well. I think the only part I would add is I think this is an area where I see opportunity for value-based purchasing. You know, in our many years of engaging in total cost of care models, that reinvestment and those savings that go back to the provider have led to investments that support those local resources, such as, you know, homeless respite services, harm reduction centers, other key pieces. So I see it to some extent as a vehicle to help support the expansion of those additional services that would support overall wellness.
Okay, thank you, Erin. Anybody else want to weigh in on that big question about the socioeconomic determinants of health?
This is Whitney from Molina, and I just wanted to say that, you know, we screen all of our members for their social needs in their initial health screening, their health risk assessments. And then we also screen as members are, you know, referred to us for case management or care management services. And I think where we're interested in working, how is it that we can better coordinate with other community-based care coordinators? I mean, and that's maybe including health homes, but how can we tie in some of the work around this area that others are doing as well?
Okay. A follow-up question, and real quickly, because I want to get to the question in the chat box. Is that something the ACHs across the state could help you out with? Representatives of MCOs, making those connections to community-based organizations.
I believe this is absolutely an area that, you know, to get some of that underway together. I absolutely think, you know, getting those connections and helping with some of that work, I absolutely think that's a great suggestion.
Okay.
Yeah,
well,
this is Caitlin. I agree. I was just going to add, Patrick, that you know, I think that all of us maybe, or at least several of us, have our own sort of community-based resources portal that we use from case management, along with 211 when we're trying to help people get access to services. And that is never complete. Like, there's always more resources to be found. And I really think we've even had some ACHs refer us to certain community-based organizations that should be on our portal. And that is always a great place for the ACH to help us, I think, because the more resources we know about, the better we can help our members.
Great. Well, I think maybe a couple of you know, but just to reiterate, the Greater Columbia ACH has developed a system of, I want to say, is it 6 or 7 local health improvement networks, and that's really one of the roles of those networks, is to bring the CBOs together and dialogue about what priorities they see in their respective regions. So I think JCACH has some resources that could help you as you move down that path. Okay, here's the question from the chat box. It's in small print, see if I can read it. Claims data seems to be real proprietary and held close to the chest, but we also recognize that you have a very important total picture of our patients, since you get to see claims data across all service areas. Do we see any hope of loosening up of the information to the providers as being possible, even if only specifically project or patient roster based? So I think you can see that question, a bit of a two-part question. Anybody want to take a crack at that? How to get proprietary, it seems to be proprietary information to.
Sure. Yeah, this is Heidi Nelson from Alina. So our value-based care reports that we do share with providers on a monthly basis includes all information at a drill down level except actual payment information, like the allowed amount, just because that is proprietary and part of it's just not something we can legally share. But we feel it's very important to be able to give providers that full picture of all care being delivered. And it is something that we use as the basis of working with providers to understand what's going on, especially with a high cost member or a member who's utilizing the emergency room more than expected. What's going on with them from a health standpoint, and what can our case management teams do in addition to medical services? What else can we do to help these folks? So it is definitely the foundational information we use and share with our providers to collaborate on this.
Okay, that's the view from Molina to that question. Any other MCO want to weigh in?
Yeah, this is Edie at Coordinate Care, and I would totally agree with Heidi. With a couple of exceptions, you know, we've had providers reach out and wanting claims-based member detail for patients that are not necessarily theirs, but they're being paid, you know, a PMPM or some type of regional incentive for providers. And so we do restrict data elements that we would share for members or services when the patient is not seeing that provider. So I don't know if maybe that's where this was headed.
Okay. Yeah, if anybody, the person who posed that question wants to respond to that, please go ahead and do that. Before we turn to the next question, any other comments from the MCOs to that question? Okay, so I think you all see the very quick question here. Number 2, how do I access my provider's patient list or the roster?
This is Erin. For contracted providers, we have an online portal where providers can access their patient roster. So I'm not sure if that's what the question is referring to. And I would assume that most of the other MCOs have a similar process. So if you were to reach out to your contracted MCOs, they would be able to direct you to that.
Okay. So fairly straightforward via I'm sure, a secure sign-in. And any other MCOs want to weigh in on that one? Is it relatively straightforward then for all of your organizations to allow providers to see his or her patient list quickly?
Yes, from Alina, it's the providers can sign in and download that from a secure portal. For our value-based care providers, we provide them with a roster on a monthly basis of their paneled members, because the information they get is for their paneled members only. So it's the total cost of care picture for their paneled members.
Correct. Yeah. Okay.
And same with coordinated care.
All right. Okay. Thank you, Aaron. All right. Any other questions from the floor? We still got about 70 folks attending, so maybe there's a question or two on the tip of your tongue, at the tip of your finger before you keystroke them in. Then I'm going to call on the Greater Columbia ACH staff to see whether they have any questions of our MCO panelists.
Patrick, I think if JD is still on the line, or Mia, and I'm not sure that they are, it just seems to me like there's a lot of conversation in the state right now around care coordination, the clinical community linkages, but it really is, I think, up to the healthcare authority in terms of their contracting with the MCOs to determine what that care coordination effort should look like, because there's so much money in the system right now that I think is could be better utilized. So I didn't know if healthcare authority had any thoughts about future contracting after hearing from the ACHs for a couple of years about how to perhaps address this this problem. JD is still on the line. I would sure love to hear his thoughts around that. And, you know, barring that, what the MCOs believe, since they are saddled with all of these requirements from the healthcare authority, how they would actually fix the system so that it's more efficient and there's a better payment mechanism for care coordination.
I think the ball is in the court of the MCOs. I don't think JD is still with us. So anybody want to take a crack at Carol's question? What would be steps to improve the payment of care coordination for the Medicaid population? Is this just a real stumper kind of question that you pose, Carol?
Well, I don't think anybody has the right answer. I think it's a very complicated question, but it would be an interesting, you know, just thought maybe somebody had some easy fixes, but I don't think that there are any.
Well, and Carol, this is Erin, and I know we've had lots of conversations about this at sort of the joint ACH, MCO, HCA tables around care coordination models. And as you said, it's complicated. I continue to go back to at least starting with the that review and alignment of requirements from the state's perspective of what they're requiring related to care coordination of the MCOs for the Medicaid population, whether that be within our contracts or the ACH contracts, just doing that review and call out of areas of potential duplication or areas for alignment, to me, continues to seem like a maybe better place, you know, might be the best place to start potentially.
Great idea.
Okay, anybody else want to take a crack at that question? Okay, well, we've got another question in the box, and we still got a few more minutes left in our designated time. So let's go ahead and take a peek at this. It says, none of the core measures are designed to measure social determinants as much as we talk about them. Until they have dollars attached to them, they won't get the attention they require. This includes the care coordination that is required to address the social determinants of health. Any thoughts? These core measures being bereft or scant on social determinants. Is that going to change in anybody's view? Or is that something that's just right now outside the parameters of the transformation project? Well, it sounds like a hard question for anybody to respond to. So maybe
I can give it a try. This is Erin.
Oh, hi, Erin. Okay.
Well, I guess I think one of our hopes was that those would have been more present in the demonstration. There was a lot of work done several years ago as part of the cross systems measure work group to outline and identify some of those appropriate measures. And at that time, HCA and the Research and Data Analysis Division at DSHS outlined a plan to gradually bring those into the core measure set. I think it's just maybe taken more time and resources than they anticipated to do that. But I think kind of looking back at the work that was created there could be a useful exercise.
Okay, so would your takeaway then, Erin, be that it still might be happening? Will there be some integration of those measures?
And I would need, obviously need HCA to weigh in on this, but that was the intent originally based on legislation that came forward several years ago and that resulted in the cross-system measures work group. And the first couple of measures that came in were around the mental health and SUD penetration measures, but those again are not really focused, I think, around the social determinants of health as this question.
Yeah, I would agree with that assessment. Yeah. Okay. Anybody else wants to take a run at the question that's in the chat box in front of you? All right. And beyond Carol, is there anybody else on the ACH staff that wants to pose a question to the MCOs, representatives? Wes must not be on the line because he usually rises to the occasion there. So those of you from the MCOs, you're off the hook, not getting a question from Wes Lucky.
Patrick, I do want to just add, though, I so appreciate being able to have this conversation with the managed care organizations. And, we've all been struggling with, the data issues and care coordination. And the demonstration, as Kat Latte is always famous for remarking about, is that this is the reason that you have a demonstration, really, is to reveal some of the warts and the bumps in our present system and try to work together to manage them and to overcome them. So I just so appreciated having this conversation this morning and having the MCOs hear from our providers directly about some of the challenges that they're having. I hope next year when we see that Sentinel survey map, the number of Vvp contracts in our area has greatly increased due to this ability of getting together and sharing information. But just have always appreciated the relationship that we have with our MCOs, and as we strive to get these pay for performance measures that are going to be delivering the dollars to our providers, I think it's becoming more and more obvious to Greater Columbia that we need to be working more with our MCOs individually. And so that was one of our goals of 2021, is to meet with each MCO independently so that we can have these conversations offline and try to see how we can't help our providers and how we can do a better job of helping our providers get into these VBP contracts.
Very good, Carol. I think those are nice summary remarks, and I would also just as the facilitator, want to thank all of you from both the provider panel and the MCO panel for taking the time to be with us today and preparing your remarks. And I hope those conversations will lead into the kind of conversations with the ACH staff that Carol just talked to. So Chelsea's reminding us that there is no meeting next month. There will be a meeting as scheduled the third Thursday of the month in 2021, the first month of 2021. We will be announcing that topic within the next month as well. In fact, there's a meeting coming up this week to go over that. And I think then we are basically ready to adjourn, unless there's anything else for the good of the order that needs to be put on the table or on the screen right now.
Just happy Thanksgiving.
That's right. Let's all have a safe and happy Thanksgiving, and know that next year's Thanksgiving will be a bit more a bit different, a bit more numerous and abundant with the people around the table. So until January, we wish you the best, and we will, as they say in German, wish you a good slide into the new year. So with that, meeting is over.
Great. Thanks, Patrick. Thanks, everybody.
Thank you.
Thank you.